So hello and welcome to this ARMA annual lecture on community-powered MSK. I'm Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance. For those who don't know us, ARMA brings together patient organisations and professional bodies working across the breadth of MSK health to improve support for people with MSK conditions. And before we start, I would like to thank Get You Better for their support for this event. We all know the challenges that are facing the NHS and health services generally at the moment, and MSK is no different. Some of the longest waiting times in elective and in community care are in MSK. There are increasing numbers of people unable to work due to ill health, and MSK is one of the top two reasons for that, alongside mental health. We know the historic challenges faced by the NHS, and those were exacerbated by the pandemic. And in MSK, there's also been a long-standing lack of priority given to what is the biggest cause of years lived with disability in the UK. Although I'm pleased to say that there are signs that that is beginning to change. Within MSK, I think there's also a realization that we may have been neglecting the psychosocial aspects of ill health and in many cases over-medicalising. And in the context of all this, I meet increasing numbers of healthcare professionals who are saying, we can't go on like this, we have to do something different. Which is why, when I read the new local report, A Community-Powered NHS, I was so excited because I could see a lot of opportunities and potential there in the field of MSK. And it's also why I'm delighted that we've got two speakers here today to explore this. Adam Lent is the Chief Executive of New Local and is in a moment going to outline the thinking behind Community-Powered NHS report. And then Laura Finucane is Clinical Director at Sussex MSK Partnership and will give her response from an MSK perspective. So I'm now going to introduce Adam to outline the main points of the report. Adam.
Thank you very much, Sue, and it is a real honour to be speaking to you this evening and see so many of you here as well. I know it's sort of a convention that you start any sort of presentation or lecture with a joke, but I'm a social researcher, which means that I'm a total geek, which means that I actually think statistics are much more entertaining than jokes. So I'm going to kick off my lecture just with three statistics, some of which you may have heard before, but I think they're pretty mind-blowing. But I think they also go to the heart of the challenge that we see at the moment in the health sector, but also public services as a whole. And unfortunately, they're not very amusing statistics, I'm afraid, so they don't even qualify as jokes in any form at all. The first stat is that mental health referrals are up 22%, and that's just since 2019. So a 22% rise in mental health referrals just in the last 4 years. The second stat is that the number of referrals to social care teams, children's services teams for investigations into children at risk of harm has risen by an astonishing 78% since 2011. So 78% rise for child at risk of harm referrals. And the final stat is the one that completely blows my mind, really, which is that currently we have 4.5 million people in this country with type 2 diabetes. And the NHS spends 10% of its whole budget on just dealing with that one condition, just treating that one condition of type 2 diabetes. But there's actually another 11 million people who are judged to be at risk of developing type 2 diabetes. So 4.5 million people already struggling with diabetes, already sucking up 10% of the NHS budget, but then potentially another 11 million people coming down the track who will also struggle with type 2 diabetes. And you don't have to be a statistician to understand the sort of pressure that is going to put on the NHS over coming years. Now, the reason I share those statistics is not just a sort of like shock and horror type impact. The reason I share them is just to indicate that the challenges we face in the public sector and in the health sector at the moment are deeply systemic. This really isn't just a matter of, some waiting lists getting longer. It's not a matter of we just need a few more clinicians trained up and ready to meet the demand. It's not even just a matter of delayed transfers, even as important as those are. There is something fundamental happening in our society, which is very significantly raising demand for care from public services and from the NHS. And the reason I say that is because it means that prevention, this shift to prevention, which of course all of you will have heard talk about and will know about, is absolutely vital. And it's not just about doing things slightly differently. It's not just about using data more smartly, important as that is. It's not just about a few more public health campaigns. And again, those are important. It's not even about doing more early intervention. I think, and we at New Local and all the work we do, think that really it is about a real fundamental shift in the way we go about delivering public services. And this is not just something for the health sector. I think this is for the public sector as a whole. The whole of the public sector has really been built around a treatment model, not just the health sector. It's been built around a model of waiting for people to get ill, for families to get into crisis, for people to lose their homes, for people to lose their jobs, and then dealing with that problem rather than preventing that problem happening in the first place. And I think that's where community comes in. As I said, it's not just about data, it's not just about public health campaigns, it's not even just about early intervention. It's about putting community at the heart of the way we deliver our public services and our healthcare. And why do I think that's the case? Well, I think it's because when you have a model built around treatment, the clinician, the specialist, the expert, the social worker, whoever it is at the heart of that process. You wait for someone to get into trouble, and then the clinician uses their expertise to treat that problem and hopefully resolve it. And of course, in many cases, that's completely acceptable. People are always going to get into trouble. They're always going to break their legs. Families are always going to break down. People will lose their jobs. These problems will always occur. But when they're occurring at such a scale, at the sort of level of sort of avalanche that those statistics highlight, then we can't just rely on the clinician anymore. Prevention is something fundamentally different. Prevention requires individuals to look after themselves, to take responsibility for their own health and well-being, day in, day out, every minute of every day. It's about shifting their mindsets. It's about lifestyle changes. It's about behavior changes. And clinicians, public servants, the experts, the brilliant professionals who work in the public sector and in the health sector can't be with people every single minute of every day. They can't be there day in, day out, making sure people look after themselves. So if we're asking individuals to look after their own health and well-being more, then they have to draw on resource, they have to draw on support and care from somewhere else rather than from the public sector professional or from the clinician or whoever works in the health service. And that support has to come from their friends, from their colleagues, from their neighbours. In short, it has to come from their communities, from the networks that they're part of. And that might be communities of place, but it could also be communities of need, communities of interest. It can be a whole variety of different types of communities that people need to draw on to sustain them, to give them the resource and the support to make the lifestyle changes they need to make to prevent themselves getting into problems in the first place. Ideally, of course, we want a system that works in such a way that someone never really ever has to come and see a clinician, never has to be treated, but actually keeps themselves so healthy and so well that ultimately they don't ever have to see someone who can treat them for a problem that has already arisen. So that means that public services and the NHS really needs to see themselves as mobilizers of the energy, the intelligence, the assets that exist in communities. And that's a really big shift, to understand that the role of health sector professionals and other public servants is to be mobilizers of communities, not just the treaters of individuals. So what does that mean in practice? How can services move in that direction? And in all the work at New Local that we do with local councils and health bodies and others, we see three main routes emerging for how public services are moving towards this more community-powered type approach, moving towards a model where communities are mobilized. And I'll run through each of those routes, and I'll give some brief examples of them, but I won't go into detail because I haven't got time. But there is loads on the internet about this. There's loads on New Local's website and elsewhere if you want to look up more about the examples I'm going to give. So the first route is around voice. So the first thing that the public sector and the health sector can do to mobilize communities is to really bring those communities, whatever form they take, into the decision-making process of those organizations, really opening out the big strategic decisions you're making about how a service is delivered, how a service is run, how it's designed, to those communities so they are part of it. And that is really important because bringing in their intelligence, their expertise, they're experts in their communities, their lives, in ways that you can never be. That will help you, that helps public sector design services in such a way that they are more about mobilizing communities rather than just treating ill health. It also itself becomes a route to mobilizing those communities. When you engage with communities and talk to them and are in dialogue with them, the opportunities begin to emerge for actually getting those communities to become active in designing, shaping, and as I'll talk about in a second, delivering services themselves. So if you look at somewhere like Camden in North London, you'll see there a local council which has made really extensive use of things like citizens' assemblies, deliberative forums, all sorts of neighbourhood forums, all sorts of ways of bringing local communities into the decision-making process. And interestingly, Camden has worked with the local health sector in North London, the ICS in North London, and held a citizens' assembly for the whole area, the whole borough, on the future of health and social care in the borough, to think through the priorities of the community and how the council and the health sector there, the NHS there, could work with the community to deliver services in a different way. But you can also look to places like Frimley. The ICS there has set up an online panel of 1,500 people in the local area and patients to draw them in through that online panel into the big strategic decisions it's making. Or places like West Yorkshire, where the ICS there has supported and helped the use of patient workshops around things like maternity services and stroke care. And that's really had a very profound effect on the way that they've designed those services and transformed them to be more about prevention and more patient-centered and more about helping patients stay out of care once they have had care, rather than return, which of course many of you will know is a massive problem in the health sector. The second route is really around rethinking the way services themselves are delivered. And I'm sure many of you will have heard of the strengths-based approach to service delivery. This is increasingly widespread across the public sector. It's basically an approach where you move away from seeing people who need care as a problem or a case that needs to be processed, and understands them more as a person, a whole person, a human being, who will bring their own strengths and assets to a challenge that they face. And that creates a very different set of conversations that a public servant will have with someone in need of support or care. But we're seeing that approach broadened out to what we call community strengths-based approach. So not just understanding what strengths an individual can bring to addressing the challenge they face or the problem they face, but actually what assets, what strengths can their whole network, a whole community bring to helping them address the challenges they face. I'll give two really practical examples of that. So one is in Essex, where the county council has set up a charity outside the county council and that's focused on alcohol and drug recovery. And the council is gradually transferring its whole drug and alcohol recovery budget into that charity. But what's really interesting about that is that that charity that's going to be delivering alcohol and drug recovery services in Essex is going to be run almost entirely, not entirely, but largely by people who are in recovery themselves. So basically the council is saying to that community of need, community of interest, or whatever you want to call it, you know best how to help people recover from substance misuse, but you also know best how to keep them sober, to stop them relapsing. So we're going to trust you with the design and the delivery of this service. We're going to be there as a collaborator, as a supporter, but ultimately the service is in your hands. Another example is in Pimlico in central London. They've taken an idea that's been very extensively used in Brazil, which is basically establishing a health worker in the community on every street. So this is someone who's not necessarily someone, there can be someone associated with the NHS, but they don't have to be, but people who are trained up to really basically go door to door, get to know the people in their street, get to know the people there, and basically have conversations with them, understand what their needs are, and communicate that back to the NHS and the primary care trust in that area. So they are understanding what people need, they're highlighting support that is available in the community before people get into trouble and need acute care. And it's really embedding that intelligence, that mobilization, that knowledge very deeply on a street-by-street basis in the local area. And the final route I want to mention is the most important. In all the organizations we work with, there's one route which every council, every health body that is any way down this track tells us is the most important, and that is culture change within their organization. Shifting away from that paternalistic mindset, which is very heavily inculcated into public services and has been for many, many decades. This idea that we're the experts, we know best, just trust us to come up with the solutions to your problems. Changing that mindset to one which basically says that if we face a challenge, if an individual faces a challenge, or an area faces a challenge, or a particular group of people face a challenge, rather than thinking, how do we find the solution to that from within our institution, rather than thinking automatically, how do we find that solution out in the community? What's the assets, what's the energy we can mobilize, that we can work with to address a particular challenge or an issue? And a very well-known example of this is somewhere like Wigan Council. Many of you may have heard talk of Wigan, which have been developing this sort of approach really for 11 or 12 years now. And if you look at Wigan and investigate what they've done, you will see that really what Wigan is about, the shift to a community-powered approach, is very largely about shifting the mindsets of the people delivering the service, and then shifting the mindsets of people in the community themselves, because many people in the community themselves are also inculcated with this sort of top-down mindset. You care for me, and I'm just a sort of passive recipient of that care. Another really good example, an international one, which some of you may have heard of, is the NUCA system in Alaska, where there was a very determined attempt to move healthcare in some parts of Alaska away from that medical model, that top-down model, to one that was really about working, in this case, actually with Indigenous people, which actually had, Indigenous people have got a much stronger tradition of seeing healthcare embedded in the community, working with them to shift the mindset of healthcare away from that top-down model to one that is much more about community values, working and collaborating with all the assets that exist in the community. And the final example I want to give before I wrap up, and I want to give this one because it really is an example of how all three of those routes, voice, delivery of services, and culture change, can be so transformational when they all work together. And again, some of you may have heard of this, but many of you may not. This is what's happened in the northwest of England, in Fleetwood, which is an area that sort of classic post-industrial coastal area, seen better days, very high levels of deprivation. And there is a GP there called Mark Spencer, who has spent 2.5 decades sitting in his surgery, writing prescriptions, the same prescriptions for the same people over and over again. And he finally had decided he'd had enough of this approach when someone came into his surgery, a man in his early 50s who'd basically been smoking 40 cigarettes a day for many, many decades. And Mark, this GP, said to him, "You've really got to give up smoking, because if you don't give up smoking, your likelihood is you're going to be dead in 5 to 10 years. And this patient said, "I know you mean well, doc, but quite frankly, if the cigarettes finish me off, it won't be any bad thing, because my life is so miserable, I really don't care if it ends early." And at that point, this GP, Mark Spencer, like, I can't carry on like this. And he got out of his surgery, went out into the community, and encouraged the local community to set up a wide variety of groups, basically to get mobilized around looking after their own health and well-being. And what it's led to is a real flourishing of all sorts of support networks and groups to help people get active, help people get out of their homes. So many people, isolation is so key to this, ending isolation. There's men's mental health support networks, there's creativity groups, there's a weekly sing-along, which is one of the most popular groups, not the sort of thing that the NHS would naturally set up, but just getting people out of their homes together to make connection, not to feel alone. And if you ever visit Fleetwood, it's really very moving to hear people there speaking about how, you know, this initiative, joining these groups, literally saved their lives. People on the brink of suicide, people who were really struggling with very severe obesity, very severe mental health problems, how being part of these groups, just being part of networks, being part of support from within their community has been absolutely transformational. So, you know, I just think that is just a really brilliant example of how, you know, when you put the power and responsibility into the hands of people, give them voice, put them in charge, rethink the way services are delivered, and change your own mindset in the way that that GP in Fleetwood did, how transformational it can be and how much it can really play a part in moving towards a preventative model. Thanks a lot.
Brilliant. Thank you very much for that. Really interesting. I can see some virtual claps in the ether. Yes, and virtual hearts. Fantastic. So that was a brilliant introduction to the concepts, and the thing that excited me when I read that report. But someone else who was very excited when she read that report was Laura, who is going to put the MSK angle on what Adam has just been talking about. So over to you, Laura.
Yeah, thanks very much, Sue. Thanks so much for inviting me. And thanks, Adam, for your talk there. I think it's very thought-provoking, and like Sue, when I read the Community-Powered NHS document about 9 months ago, I was really energized, and it made me think, gosh, you know, how can we do things differently, because we do need to do that. And it kind of left me thinking, well, you know, this has got nothing to do with MSK, but it has everything to do with MSK. And, you know, how do we translate this into something meaningful for the MSK community? And, you know, I probably don't need to say this, but, you know, because I imagine most people in this room know, you know, kind of the problem we're facing from an MSK perspective. You know, we've got this increasing global burden, which is increasing. You know, that it's going to rise. Those figures are going to rise on the backdrop of a aging population and increasing prevalence of non-communicable diseases, you know, such as diabetes, which Adam has talked about, cardiovascular disease, cancer, chronic respiratory diseases. And, you know, the patients that are coming to us through the door are not just coming with an MSK condition, they're coming with a range and raft of morbidities, mental health issues, social and well-being, all sorts of things, which are making it really challenging and complex for us to manage these patients in the kind of system that we're working in currently. And just focusing on that MSK issue is really just not good enough. We're not doing our patients a great service, I think. You know, we know, you know, Sue's talked about there are long waits. We know there's inequity of access to services. We know that staff morale is really very low, you know, across the board, I think. But I also see that there is, you know, for people delivering MSK services, I think this is a really exciting and crucial point in this at this time, that we could be doing things very differently. And there's lots of things that are going on. I definitely can see that there's a sea change occurring. I think but it is going to take us a lot of effort and to be brave and courageous about what we do in terms of turning some of these things around. And just, you know, just thinking about, you know, musculoskeletal conditions are part of the major condition strategy, and I think that is a huge step in the right direction. You know, we need to get involved in that. We need to be able to influence, you know, what comes out of that strategy. I think it's, you know, there are other things going on. We've got the MSK hubs that are, you know, they're looking at transforming, you know, community spaces like leisure centres to see if they can, you know, deliver accessible and affordable personalised services for exercise, rehabilitation, etc. So again, you know, we'll see how that plays out. We know that prevention is beginning to get some attention. You know, there's a financial commitment to work on the prevention piece. And I think certainly from within the MSK world, you know, we have a massive part to play within the prevention piece. And I think, you know, we need to pay attention to that as well. I think for most people, it's going to feel like, wow, this is a massive mountain to climb. You know, when I listen to Adam, I think, gosh, well, where do you start? You know, it is massive. And I guess, you know, it's a bit like, how do you eat an elephant? You eat it, you know, one bite at a time. And, you know, some of the things we've looked at within our service on the back of reading Adam's Community-Powered NHS and a few other things, you know, we started to think about, well, what can we do? What is it that is possible in this space? And some of the things I'm going to talk about are not rocket science. These are not extraordinary things that we're doing. I think it's just that we're trying to think about how can we get into the community? How can we actually start to use that community power to help the MSK sort of piece around this? And, you know, Adam's talked about these 3 routes to community power. And I could probably give you an example where, you know, to each of those 3 areas. But I think the one I really want to talk about is the cultural change, because I think that's something that we feel really strongly about. You know, we read the document, and what we committed to was kind of creating the right conditions to allow our clinicians to support people beyond that MSK condition. It can't just be about the MSK condition. We've got to look at that person holistically. We need to lean into the local community services. We wanted to really embed that personalised care piece, focus on prevention and health promotion, try and reach the people that really need us, and support our staff. So I'm going to talk about something that started as an idea, then we kind of created this experiment, which we've sort of done half of the experiment. So I'll talk to that. And what we did was we created this community appointment day, which basically talks to most of the things I've just described, really. And so we're on this journey to try and see, what difference that will make to our population. So what we did was we invited everyone who was sitting on this waiting list. So we had, long waiting times, but we invited people to attend this day. But what we wanted to do predominantly was to remove the things that were getting in the way of delivering really good quality personalised care. So for example, like being in the hospital setting. So what we did was we hired a sports hall so that we could de-medicalise the experience and remove the kind of the walls and the doors, the closed doors, create almost like a cafe style environment to take part in. We wanted to minimise note taking, except when it was really necessary. So we're often sat in front of our computers, we're writing notes while we're having this dialogue with patients, and we're not as present as we could be because of that, that need to write these notes. And so we made the decision, right, we aren't going to take notes, but what we're going to do is we're going to give our patients a passport. It's for them, it's their responsibility. It's going to capture the things that they found out on the day, what information they were given. If it was exercises, they would all be put into that passport with support as was needed, essentially. But most importantly, the thing that we really wanted to take away was the pressure of time. We're often in clinics and we're having to do 30 minutes or 40 minutes, and then the next patient comes in. And we were really keen just to remove that pressure of time so that clinicians could spend as long as they wanted to with that individual. If they took 10 minutes or half an hour, it didn't matter. There was no pressure. And the patient could stay within the whole of the room for as long as they wanted to. We started, sorry, the other thing was that we wanted to really sort of engage our staff. So, Sue said, morale is low. We knew that our staff were feeling burnt out. Some of them were saying, I just can't sustain this kind of pressure. They were feeling disconnected, isolated, just unsupported, really. So we wanted to really create something that actually would give them an opportunity to do things differently, to connect with each other, to have the support, to be able to tap into each other's expertise and just be part of that team and have a sense of team and belonging. So we invited everybody, on this day. Everyone who attended had started the day with a what matters to you conversation. So their journey started with this very personalized health coaching and motivational interviewing kind of approach style conversation, because we'd done some work around looking at these conversations. And basically what we knew was that if we got that conversation right and we absolutely nailed what mattered most to that individual, then it was, that the journey would be really easy. The next steps would be easy for that individual. We also knew that on previous work that we've done, the data we've looked at is about 25% of people were supported to self-manage. So they didn't need any other intervention from us. They just needed some help to manage within that conversation. So we knew that we could help people on that journey. So once they'd had that conversation, they then had the options to have a one-to-one assessment, advice and guidance, rehabilitation, and they could access any of those things, and they could access all of them, or if they felt they needed to, or just have the conversation depending on what was required. We then we also put together this health promotion hub, which essentially was information about prevention, looking at healthy lifestyles. They could have their weight and height measured. They could have their BMI looked at. They could have a diabetes check. They could have their blood pressure taken, and just information, the NHS quiz about how healthy you are. So all information that they could access and just step in and do some physical tests as well. So things like balance tests, and then decide what to do with that information. But the other thing that we did was we invited a number of community services to the event. So what we know is that we often signpost individuals to those community services, but actually very little or very few of those sort of signposting actually turn into any kind of intervention. And so we invited a whole raft of different services. So like health and wellbeing, we'll have to look at this because I can never remember, but weight management, citizens advice, alcohol, falls prevention, social prescribers. We had some women's health, talking about women's health, employee Crawley, carer support, Samaritans. So there were a range of these social community-facing services who were there on tap to pick up anything from these individuals. And so when we've looked at the data, we saw about 270 people on the day, and about a third of those people required a follow-up with us back at base. The majority of people, it was over 50%, and some of the data is a bit, you have to bear with me, we're just trying to nut this out because this was only a couple of weeks ago. But over 50%, 6% were discharged or put on a PIFU, so a patient-initiated follow-up. So they were supported to self-manage their condition. About 30% so about a third of the people we saw wanted a one-to-one assessment. So that was available. In terms of who accessed the community services, again, we think it's around 30% of the people on that day ended up going to visit one of the community services, and they either had a conversation or that became an intervention as part of that piece. And whilst, one of the focuses was, we might get some of our wait times down. It wasn't the main focus for me. One of the main focuses was really to bring our team together, to give our population something different, to lean into that community piece. But the thing that really made me happy, I guess, was that the staff were smiling. They really enjoyed the day. They had a great experience. The feedback we had from patients was phenomenal. We had lots of kind of, yes, do it again. This is really worthwhile. Really enjoyed seeing a raft of people, just some really, really helpful things that came back from them. But we did take 5 weeks off our waiting list, which is, really quite extraordinary, I think. And we are halfway through this experiment. We've got another day coming up in Thursday, in fact. So again, it's a different locality, but again, we're doing exactly the same thing, and we'll sort of compare those 2 days to see what other information falls out of it. So that's our experience.
Brilliant. Thank you very much, Laura. So that's one person's response to your report, Adam. But I'm hoping that this webinar will spark other people to start thinking differently about things that are done. And what I love about what Laura just said is there isn't a conflict between making things better for staff, making things better for patients, and bringing the waiting list down. There are ways of achieving things that don't just involve making staff work harder and more. So I just think this is something that there are probably a lot of people on this call who will be able to pick it up and run with it. I know that we had quite a lot of MSK service managers who registered for this, so hopefully that will be great. And yes, people are beginning to put questions into the chat, so we will start into the Q&A. So we will start to pick up some of those. But one of the things, just before we go to the questions that have been posted, that I wanted to raise, I have to raise this everywhere because it's one of ARMA's priority areas, is health inequalities. And I'd just like to ask each of you how you think this plays into tackling the health inequalities, because they are fairly substantial in MSK, and deprivation is one of the leading reasons. And the inquiry we have going at the moment, we have quite a lot of comments coming in about all these new ways of working in self-management. Is that helping? Is that actually exacerbating inequalities? So maybe Adam first, and then Laura, what's your reaction in terms of how does this play into health inequalities?
Yeah, thanks, Sue. I mean, obviously there's so much could say about that, but I'll link my comments to one area, which is that, we know the we know that if you, as you said, Sue, if you live in a poorer community, you're much more likely to suffer from ill health, poor mental health, family breakdown, all the things we've been speaking about. There is so much research now, academic and other research, that when you actually speak to people in those communities about what they want, one of the things they often say, a most common thing they say, is we want to be listened to. We want to be heard. We want services, the other sort of help that we're supposedly getting, to be shaped more around what we know we need. And I've heard people say, and I think it's completely right, that, you know, the people who are most expert in dealing with the challenges they face are the people who face those challenges. But the way that the health system and the wider public sector is set up is that it sees those communities, those people, as passive, that it infantilizes them and assumes that we know the solutions to their problems. If only we could, like, you know, apply them, we had enough money to apply them, or we, you know, could reach those people. So that's why I think, just on one level, there's many other levels, but I'll just mention this one for the sake of time. That starting point of giving people voice and listening to them and engaging with them, responding to them, has to be the starting point for addressing health inequalities in the UK. You know, it just seems to me to stand to reason. As I said, the research on that is so strong now. And the research also shows that when services and initiatives start with listening and start with engaging in a really open way, you're much more likely to get much more impactful services.
Thanks, Adam. And Laura, if I can ask you to respond to that. And there's also been a question about, do you know who turned up on the day? Did you look at geography and deprivation and ethnicity and those sorts of things?
Yeah, so it's a piece that we are working really strongly on at the moment. And I think when I look at Adam's routes to community power, one of them is voice. And so one of the things we do on a regular basis, every 2 or 3 months, we go out to the community and we have what we call the big conversation. And we're very fortunate. We have patient partners who are employed in our organisation who lead on that. And basically we're going to them to say, what is it you need from us? How can we support you? And we're going out to some of the most deprived areas to really kind of engage, because there's some data that's out, in terms of our population is quite surprising. I think I was really surprised that 37% of our population that come to us describe themselves as being disabled, which I think it's a phenomenal number. And of 33% are carers for other people. And so what we're doing is we're drilling down into that data. We're trying to reach those people that we know that don't have digital access. So one of the parts of our community day was we needed to reach those people, because what we were asking people to do was we sent them a text to say you can self-book onto these things, but there's people in the community that don't have that access. So we ended up writing letters to them before the event to try and get them into the system, to allow that and support them where they needed support. We'd ring up those people to try and get them into the service. So in response to the question, what was the question, Sue, about the inequities in terms of the day? So we can look at that. We haven't fully explored that, but the one day, as in we haven't looked at the data, but I know that that's possible, and we're looking in to see where those individuals have come from. Again, this is about trying to go where we need to be, where people need us. It is really about going there. I think for me, it's about going to the places where people are less likely to come to us, because they won't. They need us to go there, really.
Brilliant. Thank you very much. There's lots of questions flooding in. I will try to manage this, and it'd be helpful if people could post questions in the Q&A. So Adam, there's one for you here. So empowering communities with decision making and allowing them to deliver their own services requires a massive shift of money and power. Do you think the NHS, local authorities and DHSC powers might release this power at scale?
So do I think they might release
Do
that
you think
power?
they will? It's going to happen.
Yeah, well, it's not going to happen overnight, that's for sure. That's my experience. It is a long road. The current ways of working are very, very well, established. And one thing we've been able to do at New Local, I think, is create a bit of a network of people working in local government and the health sector and elsewhere who are really enthused by this agenda. We do often hear from them that they feel sometimes like they are, swimming through treacle. There always seems to be lots of reasons not to make this shift. And one of the reasons we wanted to bring them together was to provide a bit of a support network for those people. But we are starting to see the shift in some areas. And I think the reason that we will see the shift happening more rapidly and more extensively is because partly, as Sue indicated in her introduction, there is a growing awareness that the status quo is very, very risky. There's always this assumption in public sector, maybe just generally, that change is risky and it's best to stick with the current system. I think the level of pressure that the NHS is under at the moment and local government is under is more and more people saying, as Sue was saying, we just can't carry on this way. If we carry on this way, we are going to go into meltdown. We already are in meltdown in some parts of the NHS. So I think that mindset shift, that look, we've got to make a change. No matter what the risks are, we've got to make a leap slightly into the unknown here, because we know that sticking with what we do is not safe. It's probably more risky than change. I think the second thing is the attitude in the centre. There is the beginnings of a growing awareness in Westminster and in Whitehall of the importance of this shift and this agenda. And I've been very heartened by the way that the Labour front bench is talking more and more about prevention as being at the heart of their agenda for public services. At the moment, I know it's a lot of talk. We'll wait and see what it means in practice. And if Labour do get elected, we'll wait and see whether they really do make the radical changes. But there is beginning to be, I think, an awareness in Westminster as well. And sadly, we are a very centralised country. The NHS, but local government as well, still looks upwards for permission to make the changes that we know need to be made. So I'm keeping my fingers crossed that there will be shift and a different message and a different agenda coming nationally that I hope will begin to break the dam, and then we'll start to see the shift really beginning to occur.
Brilliant, thank you. Laura, I don't know if you want to add anything to that, but there's a question specifically for you that might relate to this, which is around what were the enablers to what you did being a success? What was needed in terms of support, planning? Yeah. How did you manage the clinical governance? All those sorts of issues.
Yeah. So that's a long answer. I'll try and give you a short answer. but essentially, one of the things that we've worked really hard on is the personalised care piece, and we've been doing that for a while. And actually, it was probably a bit more of a light bulb moment, 9 months ago, thinking, we've got to embed that even further. We know that there's real if we get it, and so leading up to the day, we made a commitment to really get our clinicians focused on that what matters to you conversations, to really take away that sort of biomedical model, really step right out of that paternalistic approach, so that everybody was able to have those conversations. And we committed to training a kind of a real core group that would do that on the day, with the intention of actually everybody needs to be able to do that. They need to hold those conversations. But that was one of the things we had to do, and we put a lot of time and effort into that. We also really concentrated on, there were two other things really that really made the day work well. One was self-booking, having the ability for people just to book into the service, because I always can imagine having 300 odd people ring, can I make an appointment? You know, that was never going to work. So we got that up and running. We also, we really concentrate on PIFU. We really focus on what does that mean? How do we embed that into this kind of approach, really? So those were the three things that we really sort of chucked everything at, I think, to enable us to get to that day, you know, and being able to focus on those things. And I think, you know, the challenges were, in part, people wanting to just pick up the current service and just stick it into the sports hall. And I kept saying, no, that's not what we're doing. We're not doing that. And it was like, well, the people can only have 20 minutes here and they can only have 30 minutes. And I'm going, no, forget the time, just stop worrying about that. We'll just see what happens on the day. So it was a bit kind of like nail biting a little bit. I was fairly confident it'd be all right, but I think people were worried that, well, what happens if we have all these people waiting to do this? But we had brilliant stewards on the day who would have those conversations about, do you know why you're here? What are the questions you want to ask that individual? You know, so the stewarding was really important to help people navigate the whole day. There was anxiety about note keeping, you know, which is not surprising. You know, it was kind of, well, you mean I can't write any notes? Not unless you're doing a one-to-one assessment, no, but you can enable the patient to take those notes and we will scan those notes in. We'll really say, you know, we'll safety net people, we'll make sure they understand what happens if something, you know, something worsens or they need some more advice. So we put things in place to try and reduce that sort of anxiety. And you know, at the end of the day, if we're having these what matters to you conversation, we're having this therapeutic conversation, not a consultation, then that patient sharing that responsibility around, you know, that kind of risk, if you like. So it's about, you know, enabling people to take that responsibility about their own care. When we're worried about something, we can have those really helpful conversations about what needs to happen next, I think.
Brilliant. And another question directly for you, Laura, is will you be publishing this?
Yes, I think we will certainly go for that.
Excellent. So here is an interesting question, which I'll see how either of you respond to this one. So how do you see this community power model applied to MSK? And this is coming particularly from the perspective of private MSK practitioners. So an awful lot of MSK healthcare in this country is delivered by private practitioners, and often people will choose not to go anywhere near the NHS. Can you see any links or ways in which private practitioners can take account of or be aware of or take this approach? Have you either of you got any thoughts on that one?
I'll leave that one to Laura.
I knew you would. I knew you'd say that. So I guess, you know, this is about, it doesn't matter if you're in private practice or in the NHS. This is about supporting somebody holistically, and it's about, you know, as Adam said really eloquently, and I can't remember exactly what he said, but he said something like, you know, this is about people taking responsibility for their health and living and breathing it. We can't be there for these individuals every minute of the day. You know, this is about us being able to support people to do that. And whether you're in a private practice or in NHS, I'm not sure there's any difference. I think, you know, it's about those networks. It's about linking into those community services that you know you can lean into, because that's no different for someone in the NHS and private. You know, you can still make those links. You can still have that ability to signpost people or you know, support them in that way, I would suggest.
Right, thank you. And certainly, I think I'm very keen, and ARMA is very keen that we don't have the NHS kind of changing its approach and having a more modern approach to MSK, and private practice somehow not addressing that, not being engaged with that. It's really important that everybody that people might talk to about their MSK health is kind of up to date with, in a way that the most beneficial way of approaching that. And this is slightly, well, not quite the same, but do any of you, either of you, see a role for non-healthcare professionals in a potential solution in the community, and especially prevention? And then the examples they give is a GP as a gym instructor with specialist training to monitor and progress people. Any thoughts on what sort of workforce we're talking about in this approach? Adam, do you want to start?
Go ahead, Adam. You go ahead, Adam.
No, I mean, absolutely. I mean, I think that is part of the shift, really, is recognizing that preventing ill health is not just an issue for healthcare professionals. There's, life is complex. We don't split our lives up into different disciplines or different public services. Everybody's life is utterly interwoven and holistic, and all sorts of factors can end up creating ill health, and there's all sorts of routes in to stopping someone getting ill. So I think part of the shift that will be made as part of this is it's about integration. I mean, I know we've talked lots about integration in the past, but it's about recognizing this is something for a whole system. And when I say a system, I don't mean a whole healthcare system. I mean a whole public service system, a whole voluntary sector system. There's a whole range of different ways in to mobilizing communities and preventing ill health. And so that does absolutely mean things like gym instructors, absolutely, but social workers, people working in the housing sector, people working on local environment, so absolutely vital. Police officers, absolutely central to this, of course. So, absolutely, we need to ultimately rethink how health and well-being, preventing ill health, maintaining well-being is the responsibility of everyone in the public sector and ultimately everyone in the community, not just professionals who are paid to do that job.
Thanks. And Laura, do you have anything to add to that from an MSK?
No, I would completely agree with that. I think, that's a conversation we had today. You've got to involve multiple people and different people to support this. It's not, it's not going to just sit with healthcare professionals. I don't think it can.
Brilliant. Well, thank you very much. That is an hour has absolutely whizzed past. And just looking at some of the emojis and claps and posts in the chat saying how much people have appreciated what you've said and how much they agree with it, I think this will definitely be something that sparks something, and I hope lots of different people will be thinking about how to apply this in whatever aspect of MSK area they work in. But I'd like to thank you both very much for your time today. That has been fascinating and really stimulating discussion. So I'm just going to stop recording.